So students, after discussing the diseases of nasal septum, let us now come and to discuss the diseases of nasal cavity. Okay. Now, whenever there is an inflammation in the nasal cavity, we call it as rhinitis. Okay. So rhinitis can be any inflammation in the nasal cavity, whether it's an infection, it's an allergy. All right. Now, similarly, any inflammation in the sinus cavity is known as sinusitis. Right? Okay. Now, you see, the nose is lined by which epithelium? It is lined by pseudo-stratified ciliated columnar epithelium. Okay. So the nose is lined by pseudo-stratified ciliated columnar epithelium. This epithelium, we know, it lies in the whole respiratory pathway. The same epithelium is found in the pharynx, in the trachea, bronchi. Okay, so everywhere, the whole respiratory pathway, this epithelium is found. So we also call it as respiratory epithelium. Right? Now remember, the same epithelium is also there in the sinus cavity. Okay, so the sinus cavity also has the same epithelium. Now what does that imply? That implies that if there is a nasal infection, if there is rhinitis, now this infection can spread to sinuses. Similarly, the sinus of infection will of course come to the nose. If there is an allergy in the nose, now we will know that the same allergy will be there in the sinus also. Okay, so therefore, to differentiate the two terms and to say that rhinitis is a separate disease and sinusitis is a separate disease is actually wrong. Right? Okay, because these are two cavities which are nearby and they are sharing the same epithelium. They are affected by the same disease. So therefore, nowadays, we do not differentiate between rhinitis and sinusitis as two separate entities. Okay, we discuss them, we treat them as the same spectrum of disease. It depends how much it has spread. So therefore, instead of using the word rhinitis or sinusitis, we will now use the common word known as rhinosinusitis. Okay, remember, in any nasal cavity disorder, one or more sinuses may be involved. Similarly, whenever there is a sinus disorder, it usually comes and presents in the nasal cavity also. Only rarely we have an isolated nasal cavity disease which is not affecting the sinus, and similarly we rarely may have a sinus cavity disease not affecting the nose. Okay, but yet the causative agents or the cause is usually common and can cause disease in both the cavities. Got it? Okay, that's because they share the same respiratory epithelium. Okay, so many undergraduate books have discussed rhinitis and sinusitis as separate disorders, but in my lectures, we will be discussing them as one disease, one entity, because that is what is the current philosophy. All right, okay, just remember that out of all the sinuses, the most commonly involved sinus is the maxillary sinus. Remember, maxillary sinus is the first to develop. This is the largest sinus, and this is also the most common sinus which is involved in infections, in sinusitis. Okay, so remember, that is true for both adults as well as children. Okay, so in both of them, maxillary sinus is the most common sinus involved in any kind of sinusitis. Okay, Right, let's first go to acute rhinosinusitis. Now, this is an acute inflammation of the nose and the sinuses. Most common causative agent is rhinovirus. Okay, in fact, if you know, this is the most common disease in the world. Okay, right? Acute rhinosinusitis. So we have cough, we have cold, sometimes we have fever. All right. So this is the most common disease that is there in the world. Right. So patient has cough. If it goes to the throat, patient will have cough. That is because of the sore throat. Generally, this is limited to the nose. So if it is limited to the nose, patient will have running nose. Okay, so running nose, that means patient will have nasal discharge, patient will have nasal congestion, some fever may be there, patient may have headache, patient may have lethargy. So all these are complaints that we find. So this is also known as common cold or flu. We call it by different names. Okay. Right? Now, what is the treatment for this disease? Remember, it is a viral infection. It is a self-limiting infection. So, the treatment is only symptomatic treatment. Okay? So, the treatment is only symptomatic treatment. Okay? Right? Now, this acute rhinosinusitis is generally caused by rhinoviruses. That is the most common causative agent. Other than that, it is also caused by coronaviruses. Now, these coronaviruses have been commonly causing acute rhinosinusitis. But recently, we had a infection by the novel coronavirus that is known as COVID-19 or the SARS-CoV-2. Okay, and this has played a lot of havoc around the world. We are all aware of this. This virus was first discovered in 2019, and that means November and December. The first cases by these viruses were discovered. Okay, now this SARS or COVID virus is a RNA virus. So as you can see that this is a single strand RNA virus. Okay, and how will these patients present? These patients also have a similar clinical presentation such as fever. There can be a dry cough. Patient can have tiredness, fatigue, lethargy. Patient can have a running nose, sore throat. If this disease spreads to the pharynx, patient can have sore throat. Patient can also have shortness of breath and other breathing difficulties if it spreads to the chest. Okay, such as patient can also have sometimes loss of smell and taste. Now this has been said to be a particularly important symptom to diagnose or suspect this infection. Right? Now, remember, most of these clinical presentation of COVID-19 are similar to the other viruses that cause acute rhinosinusitis. Okay? Remember, this disease, this infection may go asymptomatic. So many people who are infected by it may not present any symptom at all. They may remain asymptomatic and they may be just a carrier or a spreader of this virus. Right? Okay. Now, how do we say that this disease, this patient is a confirmed case of COVID-19? So what is the definition? The definition is that a patient who has tested positive for the COVID-19 test. Okay, so that is a SARS-CoV-2 nucleic acid test. So we can do a RT-PCR test, or we can do a nowadays rapid antigen test. So any patient who has tested positive for any of these tests is a confirmed case, or a patient whose virus is isolated in the cell culture, okay, or a patient who has presence of SARS-CoV-2 IgG antibody which were not there earlier. Okay, these antibodies, they may be similar to the other coronaviruses also. So a patient who did not have the antibody earlier develops the presence of the antibody, or maybe he had antibody but there is a recent increase in the titer of these antibodies by at least 4 times. Okay, so these patients are said to be confirmed cases of COVID-19. Okay, other than that, we can also use some clinical criteria to diagnose. What are the clinical criteria where we suspect? Number one, patient is having fever. So in these few months, any patient who's having a fever or there is a history of fever, along with that, patient has acute respiratory infection such as cough, shortness of breath, sore throat, or patient has loss of smell or taste. Okay, so these were the criteria where you will suspect a patient to have COVID-19, and they may be advised further testing such as the rapid antigen test or the RT-PCR test to confirm the case, right? Okay, now what is a probable case? A probable case means a person who has been detected SARS-CoV-2 IgG antibody, okay, and he has a compatible clinical illness. So we don't know what was the status of this IgG antibody earlier, whether it was present or not, whether there is an increase in the titers or not, but he has the antibody and he had a history of fever or cough or breathing difficulty. Okay, so that's a probable case, and this patient should be in that epidemiological area. Okay, so that like he may be in contact with some other patient, or he may be in a area where this disease is prevalent. Okay, now what is a suspect case? Suspect case, you have to take your clinical as well as public health judgments to suspect a case whether the patient requires hospitalization or not. Okay, now, so what were the epidemiological criteria which were used to isolate these people? Okay, so in 14 days prior to illness, patient may have been a close contact with a confirmed or probable case. Patient may have had an international travel. Patient may be a traveler on a cruise ship because one of the cruise ships was found to have a cluster of patients which were positive. Patient may be a healthcare worker, okay, or essential care worker, or a staff which has a direct patient contact, okay, or patient may have lived or traveled through an area which has a high community transmission. So these criteria were used to isolate or quarantine these people who were suspected to have this disease. Okay, now what do I mean by close contact definition? This is also important, especially in case of healthcare workers. What do we mean by a close contact? We know that the COVID-19 has a very high rate of spread. Okay, so what is the close contact meaning? Close contact meaning means face-to-face contact for more than 15 minutes in 1 week with a confirmed or a probable case. So more than 15 minutes nearby face-to-face, especially without mask. So that is the first thing. Number two, you share a close space such as air travel for more than 2 hours with a confirmed case. Okay, so that is considered as a close contact. Now, this question was asked in the FMG August 2020 exam. A doctor posted in ICU. All right, so you see, doctor, we have a healthcare worker posted in ICU. So he is posted in a place where he may come in contact with lot of patients who are having COVID-19. Came to ENT OPD on April 2020. So we know this disease COVID-19 was not there before November 2019. So this patient, this doctor is treating the patients in the ICU. The date has been mentioned specifically is April 2020, when it is likely that there may be a lot of COVID-19 cases in the ICU, came to the ENT OPD with loss of smell and taste for 3 to 4 days. Okay, so as I was telling you, loss of smell and taste were taken as diagnostic symptoms, especially in early disease or in asymptomatic people. Okay, now it says there is no history of trauma. That means trauma is ruled out as a cause for loss of smell or taste. So that means there is no neurological trauma. Okay, so in this doctor, you suspect a close contact with a positive COVID-19 positive patient, and you suspect that this doctor may also have contracted the same disease. So what will you do? Your next suspect, this is a suspect case. Your next step in this case is to test this doctor for the COVID-19. Okay, so the doctor has to undergo COVID-19 test. You can do a rapid antigen test or you can do a RT-PCR test. All right, for both these tests, you have to take a nasopharyngeal swab. So you have to take a nasopharyngeal swab and you have to send that for RT-PCR or the rapid antigen test, which can be done at that moment only. Right? So this is the next step in the management. All right. So I'm sure for COVID-19, a lot of information is available. I just wanted to discuss a little bit about this COVID-19, okay, so that you are aware that this symptom, especially the smell and the taste, this is one of the earliest symptoms or the symptom which is seen in otherwise asymptomatic patients, and it helps us in diagnosing the COVID-19. Okay, right. Let's go ahead to acute bacterial rhinosinusitis. Now, acute bacterial, how does this differ from acute rhinosinusitis? There is a bacterial infection, most common bacteria. Now, the most common bacteria is Streptococcus pneumoniae. Also known as pneumococcus. Okay. Other than this, we may also have infection by Moraxella catarrhalis and Haemophilus influenzae. If you remember, we talked about the same bacteria when we discussed about acute otitis media in the ear. You remember, where does the infection in acute otitis media goes? The infection goes from the nose and nasopharynx. So if that means the same bacteria which are in the nose and nasopharynx, they spread to the ear through the eustachian tube, and there also they cause acute otitis media. Okay, so remember, it is the same bacteria. Now, in acute bacterial rhinosinusitis, what will be the patient complaint? So patient complaint will again be the same. The patient, you see, in case of acute sinusitis, will again complain of fever, cough, headache. Okay, patient can have localized areas of pain. Patient can have thick nasal discharge. Okay, so now the symptomatology is same. How will we differentiate acute bacterial from acute, or I will say acute viral rhinosinusitis? The differentiating point is the nasal discharge. The differentiating point is nasal discharge. Remember, in case of acute bacterial rhinosinusitis, we have mucopurulent discharge. Whereas in case of viral, it is a mucoid discharge. Okay, so mucoid discharge is a colorless discharge, whereas mucopurulent discharge is a yellowish or greenish color discharge. So whenever you see a yellowish or greenish color discharge, remember it is more likely a bacterial rhinosinusitis. Okay, viral has mucoid or serous discharge. Okay, now treatment for acute bacterial rhinosinusitis is the same as viral. We give symptomatic treatment, but along with symptomatic treatment, now we also have to give antibiotics. Remember, there is bacteria, so you have to also give antibiotics. Okay, so acute bacterial rhinosinusitis, symptomatic treatment, plus you can add antibiotics. So you all, when you have to add antibiotics, remember antibiotics are not needed. In all cases of rhinosinusitis, you have to see if there is a mucopurulent discharge, that means it's a bacterial infection, then only you should add antibiotics. Okay, let's come to chronic rhinosinusitis. Now, what do I mean by chronic rhinosinusitis? Chronic rhinosinusitis, when the infection persists for more than 3 months, 12 weeks, then we call it as chronic. Remember, acute is less than 2 weeks. Okay, subacute is 2 weeks to less than 12 weeks. And when it is 12 weeks or more than that, then we call it as chronic rhinosinusitis. Okay, now the chronic rhinosinusitis, most common causative organism is Staph aureus. So Staphylococcus aureus, this is the most common causative, but generally we have mixed flora. So in the mixed flora, you may have Klebsiella, you may have E. coli, sometimes you may even have fungi. So we have mixed flora in chronic rhinosinusitis. Right? Now this chronic rhinosinusitis is a disease of chronic hypertrophy. Okay, it's a disease of chronic hypertrophy. Because of infection for a very, very long time and the associated chronic inflammation, these sinus opening cut because of chronic infection and the associated chronic inflammation. These sinus linings, the mucosa over here, they undergo hypertrophy. Okay, so there is chronic hypertrophy. Because of this chronic hypertrophy, the sinus openings get blocked, and the pus and the secretions, they get accumulated inside the sinuses. They are not able to go out. Okay, now remember, because of the chronic nature of this disease, symptoms such as acute pain or fever may not be common. But because of this hypertrophy, the obstructive symptoms are more common. Okay, so in case of chronic rhinosinusitis, we have more of obstructive features. So remember, any disease which will be chronic will have more of obstructive symptoms in the nose. Okay, so what kind of obstructive symptoms you will see? You will see more nasal congestion and obstruction. Okay, so there will be more nasal congestion, there will be more nasal obstruction, so patient have difficulty in breathing through nose. What else? The obstructive symptom, the sinuses may be blocked. Because the sinuses may be blocked, we may have collection of these secretions in the sinuses. Okay, so that will create a dull aching pain. Remember, for maxillary sinus, you'll feel the pain over here in the cheeks. Okay, there will be acute pain in acute maxillary sinusitis. Okay, acute pain. In case of chronic, it will be a dull aching pain over here. Now similarly, for the frontal sinus, the pain is over here in the frontal region. Okay, sometimes pain may be over here, just below the eyebrows. For ethmoid sinuses, the pain is around the bridge of the nose. Okay, for the sphenoid sinus, the pain is in the occipital region. Right? Okay, But remember, for chronic diseases, these pains are generally dull, aching pain. Right? Now, for frontal sinus, we have a very particular type of headache that is known as office headache. So what do we mean by office headache? You see, the frontal sinus is inflamed. Because of that, the mucosa has become thickened. Now, what do we mean by office headache? You see, because of the chronic inflammation, the mucosa undergoes hypertrophy, and that significantly narrows down the sinus ostium, the sinus opening. Now, when the patient gets up from the bed in the morning, the secretions have accumulated inside the sinus. These secretions, they start putting pressure. Slowly and slowly, because of this constant pressure, the patient starts having headache. The secretions are not able to go out freely from the sinus. Okay, so patient starts having headache. This headache will keep on increasing and will be at its peak around 10 to 11 a.m. when the patient reaches the office. So generally you reach the office between 9 to 10. So 10 to 11 patient will be having a very severe headache. Okay. Now, after that time, because these secretions are putting a lot of pressure, and from the ostium which has narrowed down, small secretions are coming out. Small quantity, slowly they will keep on coming out. Okay. And in the afternoon, slowly all these secretions will clear up. So by the time 5 to 6 p.m. when the patient starts from the office and reaches home, all the secretions from his sinus will be cleared out and this patient will have a relief. So his headache is mainly during the office hours. Okay, so we will term it as office headache. Okay, so remember, this frontal sinus has a rhythm. The headache is more during the office hours because of the particular position, the anatomy of this frontal sinus. Okay, now how can we treat a patient who has presented to us with chronic rhinosinusitis? So let's say we have a history of a patient who's having these symptoms for last 6 to 8 months, and he's tried a lot of treatments but they have not worked. So what treatment will we offer? So remember, whenever a patient of chronic rhinosinusitis comes to us, the first thing that we have to do is we have to take a nasal swab and send this for culture and sensitivity. Remember, we need to know what is the causative organism and what is the sensitivity pattern of this organism. As I told you, we can have multiple organisms. Patient may have a history of already taking the antibiotic. Okay, so the organism may be resistant to that antibiotic. So unless we know the culture sensitivity, we cannot properly treat this patient. So once we have the culture sensitivity, we can give the culture directed antibiotics. Okay, other than these antibiotics, we can also give this patient nasal decongestants. These nasal decongestants will open up the sinus openings, the pus, the secretions which have accumulated, they can come out and patient will have a relief. Okay, so culture directed antibiotics plus nasal decongestants. This medical management, this is the treatment of choice for chronic rhinosinusitis. Okay, so remember, this is the treatment of choice. But many a times it happens that we give this treatment, but the patient does not recover. Patient does not improve. Why? You see, sometimes what happens, we have a particular anatomy. Because of the inflammation, the sinus opening is completely blocked. Now, because the sinus opening is completely blocked, the secretions have accumulated inside. Okay, now these secretions which have accumulated inside, they will not come out by simply giving the nasal decongestants. And unless you remove these secretions, you remove the pus from here, the patient will not improve. Okay, so now what can you do? See, previously a surgery used to be done which was known as antral puncture and lavage. So what was then done in antral puncture and lavage? In case of antral puncture and lavage, what was done was a puncture was made in the maxillary antrum from the inferior meatus with the help of trocar and cannula. Okay, so an antral trocar and cannula was used and a hole was made in the maxillary antrum. After the hole, the trocar will be removed and only the cannula will remain. So you see, after this, only the cannula will remain, and through this cannula, we will do lavage. Lavage means wash. So antral wash or antral lavage was done. So you will wash this antrum with the normal saline and you will take out all the pus. Okay, so once you take out all the pus, patient will have immediate relief. You see, all the pus has gone, patient will have immediate relief. So this was a quite a good miraculous cure. But the problem with this treatment was that you are not treating the cause. You are not treating the pathology. There is an obstruction. Most of the time this obstruction will remain. So the secretions after a few months, they will again accumulate, giving trouble to the patient. Patient will have to keep on coming for this antral puncture and lavage again and again. Okay. Nowadays, we do not do antral puncture and lavage. So as you can understand that this treatment modality has a basic problem in the concepts, because we are not treating the disease, we are not treating the pathology, we do not do this treatment nowadays. So what is done nowadays? Nowadays, we do an endoscopic treatment. So under the vision of this endoscope, we go inside the nasal cavity, okay, and once we go inside the nasal cavity, we remove the cause of obstruction. So suppose we know over here that the uncinate process and the Haller cell, we have an enlarged Haller cell which is blocking the sinuses, so we'll go and remove them. Okay. Similarly, we'll go and remove. If some other cell is also causing obstruction, we may remove them. So depending upon how many sinuses are involved, okay, which are having the blockage, we'll go and remove the sinus obstruction, will make the ostium wide, okay, so that all these secretions, they can come out, they can drain. This is known as FES. Functional endoscopic sinus surgery. Okay, so this is the treatment modality that is used nowadays, FES, functional endoscopic sinus surgery. So what is done in this surgery? Now in this surgery, the sinuses are opened so that they are naturally able to drain themselves with the help of mucociliary flow. Remember, these sinuses are lined by mucosa. Which mucosa? Pseudostratified ciliated columnar. So they have cilia. When these cilia beat, they can remove all the pus and the secretions, provided the opening is wide open. Okay, so that known as mucociliary flow. The FES re-establishes this mucociliary flow and makes these sinuses functional. So that is why this is known as functional endoscopic sinus surgery. Okay, now somebody asks you, once again I will remind you, somebody asks you, treatment of choice for chronic rhinosinusitis? So remember, the treatment of choice is medical management. Okay, the treatment of choice is medical management. FES is a reserved treatment for patients who do not respond to medical management. Okay, got it? Don't get confused in the exam. Treatment of choice is still medical management. FES is a reserved treatment for this disease. Okay, right. Now, the question, gold standard investigation before FES, functional endoscopic sinus surgery. So what are we doing in FES? We are opening the sinuses. We are removing the cause of obstruction. Now, where can we see the obstruction? So remember, the obstruction is generally because of the variable bony anatomy, as I have shown you in the previous slide. Okay, and how do we see this bony anatomy? We see it in CT scan. Remember, this is the film of CT scan. I have already discussed this CT scan with you in the anatomy of the paranasal sinuses. So, the investigation that you will do before FES is CT scan. Okay, so that is your answer. Okay, now there is another question, a variable question that may be asked. This was the question, gold standard investigation before FES. Suppose I ask you gold standard investigation to diagnose chronic rhinosinusitis. So how will you diagnose? You see, the gold standard investigation, that means it has to be 100% confirming, is antral puncture. You make a puncture in the antrum, you collect the pus from here and you do a culture sensitivity. Okay, so that is the gold standard investigation. But this is an invasive investigation. We don't do it nowadays. Remember, we don't do this investigation nowadays. Instead of doing this investigation, what we can do is we can take a nasal swab, or you can take this swab under endoscopic vision. Okay, right? And because if the medical management fails, we may have to go for FES. We can also do CT scan. So CT scan is generally done when the patient has failed medical management and you are planning for FES. Okay, because that is the gold standard investigation before the FES. Now, let us come to allergic rhinosinusitis. Now, the first question about allergic rhinosinusitis is, what is the most common causative agent? Now, whenever I ask this question, the first answer that everyone will give me is pollen. Now, I like to remind you that the pollen grains, they are more common in the rural areas. Okay, you see, the pollen, the agriculture is more in the rural area, so pollen is more in the rural area. But allergy is more common in urban areas. Okay, right? Why? You see, the most common causative agent, as you can see in this photograph, is not the pollen. It is rather house dust mite. Okay, the scientific name for them is dermatophagoids. There are different species such as the Farini, Dermatophagoids farini, or we can have the Dermatophagoids terranis sinus. Now, these are also known as carpet dust mite. These mites, they live in our houses. They live in the carpets, cushions, curtains, bed sheets, sofas, pillow covers. Okay, they feed on the dead epithelial cells that falls from our body. Now, the dead remains of these mites, okay, dead remains and the fecal matters, these get suspended while dusting, and if they are inhaled by a sensitive person, they can cause allergy. Okay, right? Now remember, these mites are killed by sunlight. That is why allergic rhinitis is more common in snowy areas. It is less common in sunny places. Country like India, where there is abundant sunlight, we don't have that much allergy. Okay, so remember, allergic rhinitis is more common in urban areas. It is more common in snow-covered areas because there is less sunlight. Also, in snow-covered areas, we have heavy carpeting, right? There are a lot of curtains, so they all add to these house dust mite. Then these are more common in high socioeconomic status. Why? Obviously, you will find carpets, curtains, all of them in the high socioeconomic status people. Now, other than this, the allergic conditions, most of the allergic conditions, they are more common in developed countries. They are less common in developing countries. They are more common in developed countries. Now the question is, why these conditions are more common in developed countries? Okay, so for this we have a hypothesis. Now that hypothesis is known as hygiene hypothesis. Okay, now what do we mean by this hygiene hypothesis? You see, whenever we are born, we have the innate immunity. Okay, so in our body, we have the innate immunity. That is what we get at the time of birth. And we acquire immunity during the lifetime. That's known as acquired immunity. Now the innate immunity can be by the IgG antibodies which are transferred to us from our mother, and it can also because of the macrophages, the NK cells and different other kind of cells that are already present in our body. Okay, now these are under the T helper 2 cells. Now whenever there is an infection or there is some other antigen, an unknown antigen is presented to the body not only acts against them by the innate immunity, it also stimulates the Th2 cells, stimulates the production of Th1 cells, and these Th1 cells produce antibody. Okay, and these antibody also act on this antigen, right? These antibodies are also further stored. This memory is stored in the memory cells. Okay, right? Now, if this antigen is presented for the second time, now the Th1 cell will be stimulated. They will stimulate these B cells or the memory cells, which will release the antibody, and this will take care of the antigen even before the macrophages or the NK cells they come into action. Okay, now this is known as Th2 to Th1 shift. Okay, so this Th2 to Th1 shift is a natural shift, okay, that takes place in all of us, and this leads to acquired immunity, and that is almost the same basis for our vaccination also. However, in case of developed countries, because of a lot of hygiene, it is believed that exposure to a lot of antigens is less. Because the exposure to these antigen is less, therefore the Th2 to Th1 shift is not taking place. And therefore this untrained immune system in later life, when it is exposed to an antigen, it behaves in a hypersensitive way, and we have a hypersensitivity reaction such as a type 1 hypersensitivity reaction, okay, which is a IgE mediated hypersensitivity reaction. So allergic rhinitis is a type 1 hypersensitivity, IgE mediated hypersensitivity reaction. All right. Okay. Now, how does a patient of allergic rhinosinusitis presents? We all know symptom of allergic rhinosinusitis. It is quite common. So what will happen? There will be excessive sneezing. Patient will have nasal discharge known as rhinorrhea. Sometime he may have watery eye discharge. There will be nasal congestion, headaches. Okay. Now all these symptoms are quite common. Now how can we classify allergic rhinosinusitis? We earlier used to classify it as seasonal or perennial. Seasonal means few months in a year, perennial means throughout the year. Okay, but instead of using this classification, nowadays we use another classification that is known as intermittent or persistent. Now what do I mean by intermittent? Intermittent means less than 4 days per week or less than 4 weeks. Okay, persistent means more than 4 days per week and more than 4 weeks. Remember, in persistent I have used the word and, so that means both of these has to be present, more than 4 days per week and more than 4 weeks. Okay, right? Now we can also classify it as mild or moderate to severe. Now what do you mean by mild? Mild means patient is able to have normal sleep, normal daily activity, work, school, everything is normal. Okay, there is no troublesome symptoms with the patient. Moderate to severe means patient's sleep is disturbed, he's having impairment of daily activity, there's problem at work or school, or he may be having troublesome symptoms. Okay, so we can also classify it as mild or moderate to severe. Right? Okay, what do you find on examination? On systemic examination, you will see that this patient is a lethargic patient. He is an uninterested patient. You'll find he is not interested in his work in office or in school, or you will have parents coming with a child who's sleepy, who's uninterested in the school or in the homework. Okay, now what will you find on local examination? So when you look in the face, you will see the patient has typical allergic or atopic faces. So what do I mean by allergic or atopic faces? Look over here in the child, patient's mouth is open. He's breathing through mouth because nose is blocked, nose is congested. Okay, what else? You can find allergic shiners. These are dark circles below the eyes. So as you can see over here, these are allergic shiners. In the allergic shiners, you can see these lines. These lines are known as Denny-Morgan lines. Okay, now this child is having a lot of nasal discharge. This is trying to clean this discharge again and again. So because he's trying to clean the discharge again and again, he is moving his hand like this, so he gives an allergic salute. So this looks like a salute, he is giving an allergic salute. Because of this repeated action, a dorsal transverse crease is created on the nose, so you can also have a nasal crease over here. Okay, right? So these things you can see on the face. We have allergic or atopic faces. When you see inside the nose, what will you see? You will see a pale bluish hypertrophied mucosa. Okay, so as you can see over here, we'll see a pale bluish hypertrophied mucosa. Remember, in case of chronic rhinosinusitis, there also you will see a hypertrophied mucosa. But in chronic rhinosinusitis, the mucosa will be red and congested. And in allergic, it will be pale and bluish. Okay, right? You may also see a lot of nasal discharge. typically this discharge is eosinophil rich discharge. Okay, so that signifies allergy. So if you test it, you'll find that this is a eosinophilic rich nasal discharge. Okay, right. Now, how can you confirm your diagnosis? To confirm, you can do skin prick test. This is the investigation of choice. Now, what is done in skin prick test? You inject intradermally. So, intradermally, the allergens are injected. Now, remember, when you do this test, you have to also have control test. Okay, so there has to be a positive control, there has to be a negative control. The positive control is taken by histamine. That means this reaction has to be always positive so that we know that the patient is responding. We have to have a negative control. Negative control is taken by saline. Okay, and we can have allergens. So look in this, there is a positive control. It is positive. There is a wheal formation, there is reddish inflammation all around it. We have a negative control over here. It is negative, there is no wheal formation. Okay, and then we can see that this patient is highly allergic to all the allergens that we have used to test this patient. Okay, so this is the skin prick test. It is the investigation of choice. Why? You see, it not only tells us whether the patient is allergic, it also tells us what are the allergens to which the patient is positive. Okay, right? So that is the skin prick test. But there is a basic flaw with this test. What is the basic flaw? The flaw is that the allergy is in the nasal mucosa. The nasal mucosa is pseudo-stratified ciliated columnar epithelium. But we are checking on the skin. The skin is keratinizing stratified squamous epithelium. So allergy is in the columnar epithelium, you are checking in the squamous epithelium. Okay, so there is a bit of a technical flaw in this test. So we have another test that is known as nasal allergen challenge test, also known as provocation test. Now this is an inhalational test. Instead of doing the skin prick, you can ask the patient to inhale the allergen. Now this allergen will produce an allergic reaction in the nasal cavity. But this test is difficult to standardize in a normal clinical practice. So we cannot use this test for normal day-to-day clinical practice. However, we can use it for research purposes only. So this test is a gold standard test because it checks the nasal mucosa for allergy, which is an ideal surface. Okay, but you cannot do it in daily, day-to-day clinical practice. Right? So for clinical practice, the investigation of choice is the skin prick test. Right? Okay. Now, before we discuss the treatment, let us understand the pathophysiology of this disease. Now, I am sure you have understood, you have read this pathophysiology in your microbiology, in the immunology topic, and also in pathology. So, I'll quickly revise this pathophysiology for you. Okay, so we know that there is an allergen. This allergen enters, and what will happen? It is picked up by the mast cells which have these membrane bound IgE antibodies. Okay, so these IgE antibodies, they will present the allergen to the mast cells, and what will the mast cells do? Now the mast cells will immediately release histamine, leukotriene, platelet activating factor. What are these? These are early phase reactants. Okay, what will they do? They will cause acute allergic reaction. Early phase reaction, acute allergic reaction. So what will the patient have? The patient will have wheezing, sneezing, urticaria, rhinorrhea, conjunctivitis. Right? Okay. So from here, we can understand a little bit of the treatment, that if for this, we can give the patient antihistaminic. So if we give any antihistaminic drug, that will block the histamine and decrease the acute allergic reaction. right? Okay, so antihistaminic are useful because they will block the histamine by competitive blockage, so they will decrease the acute allergic reaction. So the sneezing, the nasal discharge, rhinorrhea, the eye discharge, okay, so all these things will decrease, but it will not completely stop because leukotrienes are there, platelet activating factors are there. So antihistaminics are little bit useful, especially if the disease will be mild, we can use it, okay, but if the disease will be severe, antihistaminics will not be enough. Okay, what else the mast cells do? The mast cells, they release interleukin 4 which stimulate the B cells, and the B cells, they release these IgE antibodies which will again further go to the mast cells and they will enhance this reaction further. You see, the mast cell is enhancing its own reaction. So if there is more allergen presentation, patient will have even a severe reaction. Okay, what else will the mast cell do? The mast cell, it releases interleukin 5. The interleukin 5 will stimulate the eosinophil, and this eosinophil will release leukotrienes and platelet activating factors, and they will cause chronic allergic reaction. Okay, so these are late phase reactants and they will cause chronic allergic reaction. Patient will have eczema, patient will have nasal obstruction. Very important, patient will have nasal obstruction. Okay, right? Now, if you think that you can give mast cell stabilizers and stop this whole reaction, so then we have to understand that this is not the only way where the patient can cause acute allergic reaction or the chronic allergic reaction. Why? Because this allergen is also presented to the dendritic cells. Now, dendritic cells, with the help of T helper 2 cells, they will stimulate the B cells by the interleukins. They can also stimulate the eosinophil by the interleukin 5. They can also stimulate the mast cells by the histamine releasing peptides. Okay, and all of this can lead to chronic allergic reaction. The Th2 cells can also release the neuropeptides, and these neuropeptides can directly cause chronic allergic reaction. Okay, so this is the pathophysiology for this allergic rhinitis. Okay, remember, a patient is having chronic allergic rhinitis, we not only have to treat the acute phase reaction, we also have to treat the chronic phase reaction, okay, the late phase reaction, which is causing nasal obstruction and is creating more problem to the patient. Okay, so let's come to the treatment for allergic rhinitis, and the treatment that we follow is the step ladder treatment, which is given by the area allergic rhinitis and its impact on asthma society. Okay, so what are the step ladder treatments? Number 1, patient is having mild intermittent. Okay, so mild, remember, no troublesome symptoms. Okay, intermittent, remember, less than 4 days a week and less than 4 weeks. Okay, so what will you do? This patient generally does not require any treatment because this is self-limiting. It will go away within a few days, maybe a few weeks. Okay, and it is not causing any troublesome symptom. So all you need to do is symptomatic treatment. Okay, so what can we do in symptomatic treatment? We can ask the patient to avoid the allergen. Number 1, you can give some nasal decongestants. Okay, they can be oral or they can be intranasal for less than 10 days so that his nose is open. And if you want to do a little bit more, you can give any non-sedative oral antihistaminic. Okay, so they can be given to give symptomatic relief to this patient, right? However, if the patient has moderate to severe intermittent or mild persistent or moderate to severe persistent, now these 3 treatment modalities may not be sufficient, then you will have to add other drugs, okay, such as the local chromome or the intranasal steroids. Remember, in all of them, the intranasal steroids, this is the drug of choice. Okay, so the intranasal corticosteroid spray, this is the drug of choice for moderate to severe intermittent, mild persistent, and moderate to severe persistent. Along with intranasal steroids, you can add other oral drugs to give better symptomatic relief. Okay, the advantage of giving intranasal steroids is that these steroids are nowadays not absorbed systemically, so the chances of these causing systemic side effects is very less. Okay, nowadays we have steroids which are having less than 0.5% absorption into the systemic circulation, and then the dose required for the intranasal steroids is very less, so it will not have systemic side effects, right? Okay, so this is the step ladder treatment for AR. Now remember, we may have a few cases of moderate to severe persistent, okay, or mild persistent, which do not respond to these medical treatment. Okay, so patients, especially moderate to severe persistent cases, okay, so persistent means more than 4 weeks and more than 4 days in a week, and moderate to severe is having lifetime problems. Now these patients are not responding to pharmacotherapy. Okay, so all this pharmacotherapy, this patient is not responding. So if this patient is not responding to all this pharmacotherapy, then we will advise this patient for immunotherapy. Now what do you mean by immunotherapy? Immunotherapy, what we give is allergen. Yes, you heard me right. For immunotherapy, what we give is allergen. Okay, you can also call it as desensitization therapy. Okay, so what is done in this? What is the basic of this? See, the patient is highly allergic, so all the pharmacotherapy is not working. So very low dose of allergen is given under supervised care, under the supervision of a doctor or a healthcare worker. Okay, and this allergen causes an allergic reaction, but this allergic reaction is very mild because of the low dose. Okay, this dosage is increased over the next few weeks. Okay, every few weeks this dosage is increased for the next 3 to 5 years. So immunotherapy, the course may last for 3 to 5 years, and we slowly increase the allergen dose till the time the patient stops responding in a hypersensitive way to the allergen. So we desensitize the immune system. Okay, we decrease the hypersensitivity of this patient, all right, to this allergen. Now remember, immunotherapy is the only curative therapy. So you are actually treating the allergic rhinitis by this therapy. All the remaining therapies, you are just trying to suppress the allergy, you are trying to decrease the hypersensitivity, especially by steroids, by histamines, but you are not treating the main problem. In immunotherapy, you are doing desensitization, so you are decreasing the hypersensitivity. But this immunotherapy cannot be used in all the patients. Why? Number one, as you can see, it has a course duration of 3 to 5 years. So obviously this much follow-up is required, and this much follow-up will be done by only patients who are desperate, who are in dire need. So which patients? Patients who are having moderate to severe persistent problem and they are not responding to pharmacotherapy. Okay, so only in them we will do the immunotherapy, but this is the only curative treatment for allergic rhinitis. Okay, now we come to vasomotor rhinosinusitis. Now what happens in vasomotor rhinosinusitis? There is a increased in parasympathetic discharge. Okay, now we know that we have the Vidian nerve in the nose. Now this Vidian nerve brings the parasympathetic supply. The Vidian nerve we have studied in the ear. It is formed by GSPN, which is a branch of facial nerve, along with the deep petrosal nerve. Okay, remember the GSPN carries the parasympathetic fibers, okay, and along with the deep petrosal nerve, which carries the sympathetic fiber, it forms the Vidian nerve. So this Vidian nerve comes to the nose, it relays in the pterygopalatine ganglion, and from there it goes and supplies the lacrimal gland, the nasal glands, the minor salivary glands, and the taste and palate. So we have studied that in the ear. Now, if there is an increase in parasympathetic discharge of this Vidian nerve, it will stimulate the nasal glands. So there is more secretion. Okay, the nasal secretions are more, the nasal congestion is more. Okay, so how will this patient present? This patient will present again with increased nasal discharge, nasal congestion, nasal obstruction that will lead to headache, lethargy, all these symptoms. Okay, now how can you diagnose this disease? You see, if you do an allergy test, if you do a skin prick test, you will find that this patient is non-allergic, right? If you do a nasal culture sensitivity test, so what you will find? You will find that this patient is non-infective. The problems of this disease, of this patient, they persist throughout the year. She's having perennial rhinosinusitis. Okay, so non-allergic, non-infective, perennial rhinosinusitis. Short form, it is also known as NANIPER. Okay, so remember, vasomotor rhinosinusitis, also known as NANIPER, non-allergic, non-infective, perennial rhinosinusitis. So allergy test is negative. The nasal culture sensitivity does not show any infective organism, and patient has a lot of complaint of the nasal discharge. Okay, the discharge is a mucoid discharge, right? Now, how will you treat this patient? For treating this patient, you can give the anticholinergic drugs. So number one, you can give the anticholinergic drug such as ipratropium bromide. So you can give an intranasal ipratropium bromide spray. Okay, so you can give an intranasal ipratropium bromide spray that will decrease the problem of vasomotor rhinosinusitis. But let's say patient does not want to take this spray for lifelong, because this parasympathetic supply, increased discharge, may last for a very long time. Patient wants relief, complete relief from this. So what will you do? Okay, so now there are different modalities. You see in this CT scan, remember we have discussed in the sphenoid sinus bone also, we have discussed in the sphenoid bone as well as the CT scan that this is the Vidian canal from where the Vidian nerve comes out. So for treatment, what can we do? So you see the Vidian nerve is coming, supplying the nasal glands from the sphenopalatine foramen after laying in the pterygopalatine ganglion. So you can see the pterygopalatine ganglion, you can see the nasal branches coming out into the nasal cavity from the pterygopalatine ganglion through this sphenopalatine foramen. So what you can do is you can give a Vidian nerve block. Okay, so you can give a Vidian nerve block in the region of the sphenopalatine foramen. Okay, so that is one way. This is a conservative way to stop the Vidian nerve parasympathetic discharge. Okay, now if that does not solve your problem, you can do a Vidian nerve cryotherapy. That is again a conservative method where a cryotherapy probe is taken, and this probe, as you can see in the inset, you can take this probe medial. If this Vidian nerve block does not work, you can go ahead and do a Vidian nerve cryotherapy. This is also a conservative method. Now in this, a cryotherapy probe is inserted into the nasal cavity. As you can see, it is inserted lateral to the middle turbinate. Now the sphenopalatine foramen is near the posterior end of middle turbinate on the lateral wall. So the probe is inserted there, and then you switch it on. It will cryo freeze everything in this. So as you can see in the insert over here, you can see that everything is being freezed, right? So you can see over here everything is being freezed. So you can freeze it for 30 seconds, and after that you will wait for another 30 seconds. So this will almost decrease the Vidian nerve fibers. Okay, so it will kill most of these fibers so that it will decrease the parasympathetic stimulation to the nasal glands. So you can see over here there's a lot of ice formation. You wait for ice to melt down, and after 30 seconds more you pull it out, and all of this generally heals in 2 to 4 weeks time, and the Vidian supply significantly decreases, right? Okay, now if the cryotherapy does not work, then you can go for surgery. The surgery is the Vidian neurectomy. Now let's look over here what we do in Vidian neurectomy. So this is a patient. You can see there's a lot of nasal secretions in the nasal cavity. Okay, so this is the CT scan of this patient. You can see over here, this is the Vidian canal. It is marked in yellow. So that was the coronal section. In the axial section, you can see the Vidian canal. Okay, the complete Vidian canal draining into the pterygopalatine fossa. Now, what we do is we go inside. This is the right nasal cavity. We remove the superior turbinate and we reach at the sphenoid sinus ostium. Okay, so we have widened the sphenoid sinus ostium. Okay, and once we look inside this sphenoid sinus, you can see that there is the Vidian canal. So you can see this Vidian canal over here. Okay, now to access this Vidian canal, we are drilling over here. So drill is being used to drill out this sinus ostium so that we can have a clear view of this canal. Okay, so now we can see the whole canal. So the canal bone is being drilled out. So you can see over here, the drill is now working over the Vidian canal bone, and the canal bone is drilled out, and you can see this whole nerve is coming in the view, right? So this bone from the canal is now thinned out and is broken so that we can take out the nerve, right? So this is the Vidian nerve which has been taken out. So now you can confirm that even with the help of image guided system. And once you have identified and confirmed the Vidian nerve, we pick this Vidian nerve. Okay, so we pick it up from the bone, and then you can go ahead and cut this Vidian nerve. So as you can see over here, with the help of scissors, we can simply cut this. This is the distal cut, and then we can also have a proximal cut. We can cut it so that there is a significant gap between the two nerves so that it should not regrow back together. We can also use some cautery. So as you can see over here, we are using the cautery so as to cauterize the end so that this nerve should not grow back again and cause reinnervation. So this is Vidian neurectomy. Now remember, Vidian neurectomy is the gold standard treatment. Okay, so the Vidian neurectomy, this is the gold standard treatment for vasomotor rhinosinusitis. Why gold standard? Because once you have cut the Vidian nerve, there will be no parasympathetic supply to the nasal glands. Okay, so this is the treatment, but we do it, as you can see, we do it at the end when the other treatment methods have failed. Now we come to the rhinitis medicamentosa. Now, what is the problem in rhinitis medicamentosa? This disease happens because of long-term use of decongestants. Okay, so rather I should say nasal decongestant drops such as xylometazoline and oxymetazoline. Okay, so it is because of long-term use. So what do I mean by long-term use? Generally these drops are prescribed for 4 to 5 days only. Okay, so any use more than that may be considered as long-term use. Why? You see, these drops, they have a very interesting phenomena that is known as rebound phenomena. So what do we understand by rebound phenomena? You see, these decongestant drops, they initially cause decongestion and they open up the nasal cavity. Okay, but if you use them for a very long time, these drops, they start developing a rebound phenomena. That means they cause a rebound congestion, right? So there is an initial decongestion which is followed by a rebound congestion. So you have to understand this fact that when a patient is using these drops for a long time, he's having this rebound phenomena, he'll put the drop in the nose, he'll feel very good because his nose will open up, he's able to breathe. But after a few hours, there will be a rebound congestion and the nose blockage will be more than what it was before putting the drops. So what will the patient do? The patient think that he's having the congestion because of the disease and he will put these drops back again to cause decongestion. As a result, he will become addicted to these drops. The frequency and the number of drops will increase and the rebound congestion will also increase and his problem in the nose will also increase. So this condition is known as rhinitis medicamentosa. There is a hypertrophy of mucosa and the turbinates because of this rebound congestion, because of the use of these drops for a long time. Okay, so what treatment will we give for rhinitis medicamentosa? Remember, rhinitis medicamentosa, these patients, they come with a clear-cut history for a long-term nasal drops usage, right? They will not give you a history of sneezing. The nasal discharge will be a mucoid discharge. It will generally be clear. There will be no yellowish or greenish color. And when you take a history, they will give a clear-cut history of use of nasal drops for a long time. Okay, these patients can be healthcare workers or working in some chemist shop. Okay, so they have an easy access to these drops. Treatment. Of course, we have to stop the drops, but the drops alone, stopping the drops alone is not sufficient. You have to decrease the congestion that has developed, and to decrease that, we give intranasal topical corticosteroid spray. Okay, so remember, intranasal topical corticosteroid spray, that is once again the drug of choice or treatment of choice for rhinitis medicamentosa. Okay, because they help in decreasing the nasal congestion which has developed. You may give a very short course of oral corticosteroids also to tide over the time when the patient has a lot of congestion and you ask to stop the nasal decongestant drops. But the drug of choice is intranasal topical corticosteroid spray.